I think due to time constraints, we are not taking an official tea break, but tea is being served outside. So we move on to the next lecture. Our next lecture is how to manage regional anesthesia in patients on anticoagulants by Dr. Murli Chakravarthy. Dr. Murli Chakravarthy is a chief anesthesiologist at Fortis Hospital, Bangalore. He has a fellowship in cardiac anesthesia. Dr. Chakravarthy has about more than 85 clinical papers as a primary author to his name. He is also the editor-in-chief of the Indian Association of Cardiac Anesthesiologists official journal. Dr. Murli Chakravarthy.
Thank you. They said there's no tea break, but the tea is supplied outside. Was not the correct choice of words. Because I am in the line of firing. If it was somebody else, maybe I would have also gone for the tea. Thank you all, because I like you all. You didn't go for the tea. All right. This topic is a very important topic because this whole conference RA, that is a regional anesthesia workshop that we have been having successfully for the past 4 years, and the growing interest in the topic of regional anesthesia is threatened by these patients who are on anticoagulation. On one hand, we have enthusiastic cardiologists who swear and show robust data. They always talk of robust data, that it prevents patients' death. They don't bother what anesthetic technique would have implications on the patient's survival. Sometimes there may not be any other choice other than to give a regional anesthesia, but the patient is on anticoagulants. We do come across these questions. The American Society of Regional Anesthesia, whose president was Therese Harlocker, she put a consensus conference in 2005, which was the consensus conference 2. And in 2010 February, the consensus 3 came up. And unfortunately, there is not much change in the two consensus meetings, second and third. That suggests that there's not a huge headway made in this direction. So what is the fate of thoracic epidural anesthesia? We, at our center in Bangalore, were one of the leading thoracic epidural centers in cardiac surgery. So patients who are getting heparinized. And this is in the last about 15 years we have been practicing. And you can see the number of cardiac surgeries is going. This is the trend line of cardiac surgery. And the number of epidurals in our center is not growing with the same rate. You can see the trend line here. Then the total number of epidurals per annum is about the same, despite the increase in the number of cardiac surgeries. That suggests that the fate of epidural is threatened in cardiac surgery. And my worry is that at least this is flat now, if not upward facing. After a few years, it will go down, and epidural will go the dinosaur way. So all your grandchildren anesthesiologists will say, you know, my grandfather used to give an epidural. Really? What is that? That kind of talk is not unknown. And the problem that anticoagulation has favorable outcomes in ischemic heart disease, that is, there is no doubt about it. And also the cardiologists, in their enthusiasm to put in a stent, bare metal to drug eluting, once the patient has a block in the coronary artery, on the cath lab table, they open his mouth and put 4 clopidogrel tablets in his mouth. And then they say, oh, it's not possible to do an angioplasty in this patient. We'll send him for surgery. So when you see, when did you receive the anticoagulant? Half an hour ago. So no question of giving an epidural for them. The robust evidence that I was talking of, you will find in plenty of cardiology journals. Everything about anticoagulation and survival is robust. Unfortunately, it's not so for us. Prevention of thrombotic events, not only the coronary events, the cerebral and the venous thromboembolism is a major issue. So it is now more or less we have to accept. If there is a patient coming up for surgery without an anticoagulation, you must be surprised that there is something missing in this patient, because some physician or cardiologist has not seen the patient yet. That is the indication. Neuraxial blocks have undeniable benefit. How many of us can say that we will give you a neuraxial block which will reduce the incidence of neuropsychiatric problems, reduce the incidence of myocardial infarction, improves your outcome? Not bothered. But this is the truth. It does. But unfortunately, concomitant use of neuraxial block with anticoagulation might produce a hematoma, and neuraxial hematoma is a bad news. That is the face of the anesthesiologist whose patient has got a neuraxial hematoma. And the regional anesthesia in patient receiving antithrombotic and thrombolytic therapy by Teresi Horlocker is an excellent document. I suggest all of you to go through that. It's very, very in detail mentioned about each and every drug. And we have been following in our institute the regional anesthesia in anticoagulated patients as per these recommendations. These are the ASRA 3 records versus 2010. There is a strong supportive role for venous thromboembolism now. That means anesthesiologist himself administers the fractionated or unfractionated heparin depending on the patient condition, and has to administer thrombolytic drugs on the table. Special recommendation for joint replacements. The joint replacement surgeons have very clearly said no epidural in our patients, because all of them are going to be on aspirin and they are going to be on unfractioned or fractionated heparin postoperatively to prevent the venous thromboembolism. The American Association of the Joint Replacement Surgeons has very strongly recommended that the chance of venous thromboembolism in patients after joint replacement is very high, and therefore it is class 1 recommendation to give them anticoagulants. And when there is a class 1 recommendation, obviously we can't use epidural or spinal in these patients. And there is more in the ASRA 3 on anesthetic management rather than blocks, unlike in ASRA. In second consensus conference, there is very clear guidelines on which block can you use, whether you can use. But here now they talk about the anesthetic management itself, saying that blocks may not be possible. So that's why this topic is so relevant. And also they talk about pregnant women receiving regional blocks and anticoagulation. Now you know that all patients who have pregnancy-induced diabetes, pregnancy-induced hypertension go on anticoagulants. Therefore, thankfully it stopped at about 36th week. And if the patient risk factors for neuraxial hematoma, which have been clearly described. What are the risk factors? Female gender, advanced age, orthopedic patients, ankylosing spondylitis, renal insufficiency, coagulopathy or use of antithrombotic medication, multiple needle passes, and catheter insertion or withdrawal. This slide is very important. Postgraduates here, please take a photograph of this, because it is to be on your table. Every day you read or go to the OT, see this list so that you don't commit any of these mistakes. So what are the alternate plans? General anesthesia, of course. Why are we behaving as if we are not going to anesthetize from tomorrow? We have general anesthesia. We will continue to do it. There is no contraindication for general anesthesia as of now, unless the anesthesiologist has a problem. Well-planned cessation of antiplatelet medication is a good idea. That was not me. Well-planned cessation is possible with a good surgeon. If you have a good surgeon who can communicate with you, you can tell them, look, if you are doing a joint replacement in a high-risk patient, cardiac patient, epidural is a good idea. Can you change the drugs? Yeah, if they can do that, it's possible. In cardiac surgery, it is of very, very great importance. We always stop the clopidogrel in patients who are likely to benefit, respiratory cripples, or patients who have other comorbidities like obesity or obstructive sleep apnea. These patients, we make it mandatory. Sometimes we tell the patient that, look, if I put an epidural, you will go home in 5 days. If I don't, you will go home in 10 days. So those additional 5 days you spend at home and come back, so that you will anyway go at the end of 10 days home. They understand and go home and come back, and we put an epidural. And assessment of platelet function is something which there is a huge amount of research going on. Whatever that we get about the platelet function now is all dependent on the thromboelastogram principle, which is you put blood in a cuvette and let it rotate, and the tensile strength that a clot produces generates a graph like this. Based on that, we work most of our hypotheses on. But unfortunately, the platelet, if you do functional analysis of some of them with respect to the damaged endothelium, may be normal even after getting drugs like clopidogrel. And I'm sure it's each and every one of your experience that the surgeon says, be careful, this patient is on clopidogrel, he doesn't bleed a drop. He says that this patient has got a hemoglobin of 18, no clopidogrel, no problem. If you want to take a couple of bottles of blood during surgery, that patient bleeds and you have to order for apheresis platelets and things like that. So that means that we have not understood the role of clopidogrel vis-a-vis the platelet function and clot formation in detail. I am not an authority to make this powerful statement, but this is my observation, and I see a lot of gray heads saying yes, yes. Countering the action of the platelets is something that we should get. The research should be towards that. But the robust evidence that the cardiologists have prevents any further research, because they say the moment you administer anything to counter the antiplatelet, patient will thrombose all over and will have myocardial infarction, stroke, and thromboembolism and all that. Therefore, we are pushed now to learn peripheral nerve blocks. Indeed, it's a good thing, blessing. More anesthesiologists have now pushed Alzheimer's away by learning, going to textbooks, learning ultrasound and all that. So they're becoming very active. Good news. Perioperative management of cardiac patient has been described by Therese Horlocker. I'm not going into the details, but this is another important slide for the postgraduates and practitioners who get cardiac patients who get stent. Only thing, please remember, the bare metal stents are safer than drug-eluting stents. Bare metal stent, you can stop medication, but as Dr. Ponde, not this one, her husband, was mentioning in the last meeting, if you want, stop all anticoagulants, but not aspirin. Please remember, it was a very good take-home point for me. Stop all medications, but not aspirin. Aspirin, anyway, is a kind drug for our regional blocks. Please remember this. That is an important part. Perioperative management of cardiac patients who are at exclusive of coronary stents. This is also described in the ASRA recommendation. So, important take-home point in this is that resume clopidogrel 24 hours after the surgery, if possible earlier. And if you cannot resume orally, give low molecular weight heparin or any other fractionated heparin of your choice. And very important to resume, and if there are enough evidences to show that early resumption of antiplatelet medication has better outcome in terms of reduced incidence of myocardial infarction, stroke, and pulmonary venous thromboembolism. And what are the antiplatelet agents? There are a lot of them. We don't know many of them. Other than the drugs we know, we have this garlic, ginseng, and a lot of drugs which are used for other purposes have antithrombotic effect. Please remember that. In a patient who is very critically ill, you are very worried about neuraxial block, go through the entire list and make sure that he is not on any antiplatelet medication. These are the antiplatelet drugs. And what about NSAIDs and aspirin? There is no additional risk for procedure or catheterization. So you are safe. However, when we wrote our document on epidural catheterization in cardiac patient, we arbitrarily defined that 100 milligrams of aspirin should be all right, because that was included in our exclusion criteria. Any patient who received more than 100, we did not put epidural. So we always mention that 100 milligrams is a good idea to give. Patient is protected, he gets both the benefits of aspirin, but also the benefits of epidural. No procedure, if there is a